So thank you for the invitation. I hope the case discussions will be interesting. So what are the rules today? So everyone needs to listen to the rules very carefully. One, you cannot enroll any patient on a clinical trial. There are no financial restrictions, and every drug is available to you 100%. So you can't play the card that your patient can't afford the medication. So this is what I want. I want people to look at the cases and tell me what they would do practically on the ground if they had all the drugs available. So there are a number of cases. I'm hoping that we will have the time to go through all of them. I think there are interesting cases. The first case is of a premenopausal woman. She's in her 40s with ER positive, HER2 negative metastatic breast cancer. It's stage 4 de novo. She presented with a solitary liver metastases. We sent her tissue for profiling, and she has a PIK3CA mutation. She also has a pathogenic HER2 mutation on exon 19. So the therapeutic options are we give her a CDK4/6 inhibitor plus endocrine therapy, alpelisib plus endocrine therapy, or neratinib plus endocrine therapy plus minus trastuzumab. So at this point, we did remove her ovaries because she's premenopausal. She was put on a CDK4/6 inhibitor and an aromatase inhibitor because that's the standard first line. Her liver lesion actually responded, and we ablated what was there in terms of residual disease, but her progression-free survival was only 8 months. She develops a sternal lesion, and this is radiated, and she has progression of disease in the lymph nodes. We re-biopsy it. It's an ER positive, PR negative now. Before it was PR positive. HER2 was 2+, and her FISH now shows an amplification at a ratio of 2.2. She receives Taxol, pertuzumab, and trastuzumab. She has a good response, and she's put on maintenance trastuzumab, pertuzumab plus fulvestrant. 20 months post-diagnosis, she has progression of disease in the mediastinal lymph nodes, and she has a liquid biopsy that's done, which shows a VAF for the HER2 mutation at 12.8%. She still has the PIK3CA mutation. So Nitesh, let's start with you, and then we go on to Vineet. What are her options, and what are you going to do now?
I think this is very interesting, actually, because this is that group of patients which, when you look at I forget the name of the trial, when you look at the San Antonio 2021, neratinib, Herceptin, with, I think it was fulvestrant.
So you're talking about the SUMMIT study,
yes.
which showed that a combination of neratinib, fulvestrant plus trastuzumab resulted in an objective response rate of 42%, a clinical benefit rate of 51%, and a median progression-free survival of 7 months in a heavily pretreated group of patients.
So I do think that this patient's, obviously, the two questions is PI3K, should I use it now versus use ERBB2? And my problem is that I will have to speak to a molecular biologist, a partner or someone, or MOSME, and see if in fact it interacts, because if alpelisib is going to be resistant because of the pathway above, then the neratinib starts making choice, and if not, then I guess I would have to go down to alpe. So I pass it on to MOSME. I'm not passing the question on.
So MOSME, you're being asked a question from Nitesh.
So look, alpelisib is usually recommended for ER positive. So this patient is ER positive as well as HER2 negative. But you already have a HER2 mutation which is sensitive to neratinib. I feel maybe neratinib may be better.
So MOSME, I think what I was trying to understand is that if I was to use...
I can't hear you. There's a lot of...
What I was asking is that if I was to use neratinib in this patient, would I have resistance because of PIK3 and other way around? If I was to use PIK3 inhibitor, would I have a resistance because of the ERBB2 pathway?
Look, for neratinib, PIK3 can be an inhibitor, but for PIK3 alpelisib, HER2 mutation, there is no data as such. So to be very honest, there is no data, clear-cut data anywhere. But since PIK3 CA has been validated in that scenario of a HER2 negative, so I would prefer like starting with that.
I-
But as
I
such, there are
somehow-
no clear-cut things.
So let's
China, I still feel I'll go for niratinib in this
niratinib.
patient.
So Shani, what would you do?
This patient has a PIK3CA mutation, and whether she's hormone positive or HER2 positive, she's going to have a much poorer prognosis and a shorter progression-free survival. So I would be more inclined to give her alpelisib-based therapy. There is safety data to give it with Herceptin. In fact, there's safety data to give it with Herceptin and pertuzumab. There was a study being run by Novartis. The study has not continued, but there is safety data to combine them, and that would be my inclination at this point.
Vineet, what would you do?
I would do
Excuse me?
alpelisib because based on the BILEAV data, that's what I would do. Alpelisib as
Hello?
plan A and
sorry.
trastuzumab as plan B.
Yes.
Sorry, just a second. It's not audible. The discussion is not audible.
It is not
And so
Yeah,
we would
so-
request you people to set the things right, and all of you please speak closely to the mic.
Okay. Can everyone at least hear me?
Yes.
Okay, so it's the people from the panel you can't hear. All right, so yes, Vineet.
So alpelisib would be my plan A, and plan B would be trastuzumab. Actually,
Maybe we can have these handheld mics. Maybe we can bring the handheld mics here instead. Okay. Can you hear the panel
this
discussion?
patient is going. Okay, this patient obviously has a long trajectory of disease, and she's going to be a chronic relapser. So we need to have a plan A and a plan B. And a plan A for me would be alpelisib, and a plan B would be trastuzumab.
So, Senthil, let me ask you this question. She has a pathogenic HER2 mutation, and her FISH was also borderline 2.2. Although this is a case that I'm actually sharing with Sudeep, and we've had a battle as to whether it was really positive or not. Why not trastuzumab deruxtecan, especially since we do have data, at least in the lung world, where trastuzumab deruxtecan actually works in patients with pathogenic mutations, and there's currently a trial that's going on looking at patients' pan-tumor type with pathogenic HER2 mutations that are being enrolled on trastuzumab deruxtecan. So what do you think about that option?
So not only lung, Shaheenah, it's there in stomach, it's there in rest of the GI also, so it works. And even in the absence of that HER2 mutation, if we assume that their HER2 is 2.2, then I would still go for trastuzumab deruxtecan, because if you look at the BILEAV, the likelihood of having a response is what? It's such a small number.
Yeah.
So I would put my money on trastuzumab deruxtecan, because that's what you would do as second line classically in somebody with a HER2 amplified cancer. And then if that doesn't work, then it's anybody's choice whether you combine niratinib plus alpelisib, then it's open.
Okay.
That's a gray area where you may want to do whatever it is. So for me, it's TDXD and then anything else afterwards, because that would be classical
Okay.
algorithm.
So let's move on to the next case. This is a postmenopausal woman in her 50s. ER is positive, HER2 is negative, metastatic breast cancer. She was diagnosed in her 30s with stage 3 breast cancer. She received anthracycline-based chemotherapy, took tamoxifen for only a year, and then stopped. She presented in 2021, I believe, with seizures and was found to have bone as well as brain metastases. We did a biopsy of that brain met. It was ER positive, HER2 negative. She goes on to receive radiation therapy, and she has an ejection fraction of 35%. This lady has actually heart problems since she got her anthracycline first time round. So we sent her tissue for profiling. You can see she has ER positive disease, HER2 1+. She has MSI high disease with a tumor mutational burden of 19. So her therapeutic options are CDK4/6 inhibitor plus endocrine therapy, perhaps pembrolizumab, and you can see she has HER2 low disease, so perhaps even trastuzumab deruxtecan. And as we know, in patients with breast cancer, about 1.7% of these patients will have MSI high disease. Now, we did go on to give her an AI plus a CDK4/6 inhibitor. Her progression-free survival was 6 months. We then gave her fulvestrant plus everolimus. PFS was 3 months, but now she has liver and bone mets. We sent her tissue, or we sent her blood for liquid biopsy, and you can see she's developed a number of ESR1 mutations. She has now an acquired PIK3CA mutation, still MSI high disease, which is not Lynch. We did test her genetically. And she's got a whole bunch of other things. So Shona, what would you do here?
So this is a really tough one. She has a ESR1 mutation, right?
Yes, she has 2 ESR1 mutations.
So I'm not sure that the IO is going to really help at this late stage because the data for subsequent lines is not great.
So she has an acquired PIK3CA mutation and she's
Yeah.
got MSI high disease. So perhaps one of the options could be either immunotherapy or an alpelisib-based therapy. She did get fulvestrant plus everolimus on the basis that she didn't initially have a PIK3CA mutation.
But now where's the data for giving alpelisib post-everolimus?
Post-everolimus.
That's
Yes.
again another question.
Absolutely. Dr. Chirag?
So,
What's the germline
Yeah.
workup?
Yeah.
Was germline workup done?
Yes, it's all negative.
All negative?
She's ESR mutation positive, right?
ESR1 mutation
And
is
we have all
positive.
the drugs available.
All the drugs are available,
about
but
oral SERDs?
elacestrant is not available yet. So that's not been even FDA approved yet.
so this patient was HER2 low.
Yes, she's HER2 low.
Yes. So why not TDXD?
EF is 35%.
So her ejection fraction was 35%.
EF
Would you be comfortable giving trastuzumab deruxtecan in
No.
someone who's got cardiomyopathy and ejection fraction of 35%?
Right. No.
I would think Pembro would be her best choice at this point in time.
Because look at her TMB, it's so high. There are so many mutations in your repair genes. I can't see from here, but what I can make out is a lot of repair genes are involved. So immunotherapy is an option from my side. Like
But,
you have to see clinically, but
Okay.
Shaheenah, isn't
Yes,
her,
yes.
Shaheenah, isn't the TMB gone up as compared to her initial mutation?
Pardon?
Hasn't
but
the
this
tumor?
is liquid biopsy. That
This
was
is
tissue.
liquid biopsy, that is tissue
But both of
profiling.
them are high. So it's like consistent with the MSI deficient patient.
Which-
Most of the MSI deficient patients will have a high TMB.
So Shani, what would you do at your center with a patient like
Can
this?
I ask a question, Shaheenah?
Oh, okay.
So do you normally have no compunctions giving pembrolizumab to a patient with an ejection fraction of 35%, knowing that myocarditis and cardiomyopathy are emerging side effect profile of immunotherapy? I would imagine that you need to take this with a pinch of salt because you have to fit in the entire paradigm of the patient's treatment
Yeah.
trajectory and the disease comorbidity. She has a
Agreed.
compromised heart. Just a little bit and she's tipped over.
Absolutely agreed, but the probability of getting a myocarditis is not that high, number one. Number two, I've treated a number of patients with low ejection fractions with pembrolizumab, and they've done very, very well. But the incidence is low is something you counsel your patients about. So I would think the pembro would be safer than the trastuzumab deruxtecan. So Shani, what would you
And
do
what
here?
dose do you use?
No, for immunotherapy, it's standard dose. You don't dose adjust based on ejection fraction.
And also another thing, she's 30 years old and she's having
No,
a
no,
high-
she's not 30 years old. She's in her 50s. Her cancer was diagnosed at the age of 30.
Okay, okay, at the time of diagnosis, still I would look into the test which was done for germline testing.
I
Because-
did her germline testing. It was she has no
because there are
germline
deletions
test.
and insertions which might be missed on your routine testing.
And I went back and
So-
I checked and I sent both reports to the company and they said there was nothing. I actually did check that. Yes, Shani.
You asked what I would do in our institution. Firstly, we don't do so much molecular profiling. I'll start by saying that as a caveat. We probably would have done molecular profiling maybe once after initial progression in a patient with endocrine positive disease. But this patient has a very bad prognosis. For a patient who has hormone positive disease to present with brain metastases, I would want to definitely confirm that it's really breast origin.
We did.
But assuming it was confirmed that it was a breast origin,
We did,
this
yeah.
is a patient, even with her cardiac problem, I probably would have offered her pembrolizumab to begin with because she has a poor prognosis. Her chance of developing any sort of checkpoint-induced cardiac problem is low. And I think at this point in time, this woman is going to die probably within a year from her disease. So I think that in terms of checks and balances and the risks of anything that's cardiotoxic, I wouldn't be too concerned. In fact, I wouldn't. Somebody brought up the option of and HER2 of the trastuzumab deruxtecan. And again, the cardiac risk there is very low. The woman's risk here of dying in the next year is much higher. So I think in terms of that, in that respect, I'm not so worried about her cardiac function.
Okay, so now let's go on to the next case. This is a premenopausal woman in her 30s, ER positive, HER2 negative metastatic breast cancer, stage 4 de novo with liver and bone metastases. We sent her tissue for profiling, and we did initially start her on a CDK4/6 inhibitor plus an aromatase inhibitor plus ovarian function suppression. You can see from her profiling report, she has an NTRK fusion, a PIK3C and a PIK3CA mutation, and her HER2 was truly negative. So you can see the incidence of patients with breast cancer having an NTRK fusion is actually quite low. It's about 0.39% of patients with breast tumors. So you can see we started her on CDK4/6. Between December 2019 and March 2020, she had a nice partial response. But by May 2020, she had progression of disease, so approximately 6 to 7 months PFS. Now what are you going to do for her? We have the option of giving her alpelisib plus fulvestrant, or she has an NTRK3 fusion, a proper fusion. So we have the option of giving her either entrectinib or larotrectinib. Dr. Abhishek, what would you do?
I think I would go with the PIK3 option.
The PIK3
I would keep
PIK3
the NTRK
option?
as the last line.
Okay. Nitesh, what would you do?
I again feel very strongly these are the reports which must be curated by a molecular board. I don't think we should.
That's why you're here. That's why you're here. So you need to tell me what you would do. You need to tell me what you would do.
So no, I'm not. I'm saying there is an interaction in these pathways, and we must know that before we start choosing our therapy.
So let me tell you, Nitesh, I went back to the company that actually did this test in the US, and they curated their entire database, which is huge numbers. They had only 4 breast cancer patients, 2 of which were mine, who had an NTRK fusion, and all 4 had a PIK3CA mutation.
No, I'm asking more at
I'm
the
just
level.
talking about
I'm asking at the
difference,
cellular level, how do they interact?
Yes.
The drugs.
No, but I'm just saying that this is the data that I have.
a question. One, what was the histology of this patient?
Ductal. It was an invasive ductal. It wasn't a
Because
secretory
usually
type.
NTRK are secretory. And about PIK3CA, look, it is not one just pathway like your EGF or some strong pathway. PIK3CA is one pathway which interacts with so many things. So your 20-25% of your HER2, your ER positive, all of them will have PIK3CA. So as such, you cannot be laying so much stress on PIK3CA. I know alpeslib is available, but NTRK3, if it is truly present, is the driver here.
So
it is like a sideline. PIK3 is like the side cross thing. Cross
that answers my question.
Correct. So if the NTRK fusion is a fusion, and then you checked up,
it's a real fusion.
So
it's
let
a
me
good
put.
fusion.
So I think it's good to compare PIK3CA versus larotrectinib or entrectinib. In terms of response, NTRK targeted therapy is much more. Alpelisib is terrible in terms of tolerance. So as much as possible, I try to avoid using alpelisib, especially if you have a borderline sugar, which most of our patients have. The PFS may be comparable for both entrectinib, larotrectinib versus alpelisib. So for me, if I get entrectinib or larotrectinib, which you already said you will get in case you want.
Yes, it's 100%. Everything is free.
So that is what I would do for this patient rather than doing alpelisib.
Yes, we have a question from the audience.
So, I mean, it looks all Greek to me, but I'm trying to understand what it means.
It is also Greek to us, Chirag. We are speaking like as if we understood everything.
So my question is that do we and should we look at the visual allele frequency, VAF? Does it make any difference in our interpretation of these mutations?
But this is a fusion. So that's different. Yes, Aparna, it's a fusion. So you wouldn't have...
VF does make a difference when it is a germ line, like it tries to tell you,
Yeah.
or if you are serially following some mutation. So it does make a difference. It can, like a TP53 with a high VF can make you think that it could be a Lee-Fermani syndrome, especially in breast.
Sudeep, what would you do here? I know you're dying to ask or say something.
Only in response to what he asked. Actually, what he's asking is, are all 100% of the cells have the fusion, or only 10% or only 5% or 50%? That's what he's asking, and
Yeah.
I think he's asking a good question. So whatever genetic abnormality, it can be subclonal, it can be only in a proportion of cells, so that will determine the response to treatment.
So Aparna, can you please answer that question?
So usually fusions are reported with reads. So she's just giving you the first page. On the second page of this report, you'll actually have the VAF, and for these fusions, the reads.
So that's what he's asking. So how much
It's-
was the variant allele frequency here?
The reads for this,
I can't remember,
I
it's
can't,
very
but
old.
I know that I recognize the lab, so I know on the second page they have that detailed.
So, from
there
a
is no data as
practical,
of
no,
now
but
to
Sudeep, you need to
differentiate
tell
the
us what
treatment
would you
based upon
do
the
for
VAF.
this patient? What would you do for this patient?
VAF will
You
be
have
dependent on the wild.
So whenever you talk about reads in fusion, so it doesn't correlate directly with the VAF, right?
But
so a fusion read will be, a small amount of fusion read will also make it a significant read.
Yes.
So the
For
point is, when you talk about VAFs, it may have a, when Dr. Sudeep said that, VAF obviously is important, but when you talk about fusions, the limited number of reads are also important. So that's where the,
Yes.
the difference of
For
VAF and read
fusion,
comes.
yes, he is absolutely right. For fusions, VAF will not make any difference because a fusion positive is a fusion positive, and we are not calculating fusion by comparing with the wild. So, but for your mutations, of course,
Can I
it
raise a
has meaning. Yes, sir.
Yes.
So I think there is a criteria for labeling of fusion positivity. For example, ALK has approximately 15%, 20% positivity to be labeled as positive. And in ALK positivity with fusion, you don't label that. If it is 75% positive, then it is more likely to respond. Whereas if it is 25% positive, it is less likely to respond. You won't have VAF values for fusion. That's for sure. But there is a cutoff. Beyond that, it is positive, and below that is negative. This is Claris, correct? So I'm sure that if they are reported, you can counter check
They
them.
don't usually report
Yes,
the
but
VAF
that
for
I agree.
fusion.
So this is positive. You don't call a super ALK positive, half ALK positive. Positive was positive. For the fusion, it is like that.
So we need to push on, but just to give you a sense, this data comes from Memorial.
If it has been reported in the report, it is positive. So that thing which Dr. Amit was saying is for the person who is reporting. If he's qualified it as positive, so there are certain number of cutoff things. So
Yeah.
it's put in the
So-
report, it is positive.
So we really do need to push on because we have a number of cases to go through. But as we know, this data comes from Memorial Sloan. This is not for breast, but for patients across tumor types that have fusions. And what they essentially showed was that even in patients who are matched to other alterations versus those patients who have other alterations but also have fusions, and you match them to the fusions, your prognostic outcome is actually superior. So a fusion does actually trump other alterations. So at this point, we had a long discussion with the patient about the pros and cons of each strategy. She chose to target the NTRK. We gave her entrectinib, and for the first time, she actually had a complete response that lasted for over a year. And then after that, unfortunately, her disease progressed. So now coming to the next case, this is a postmenopausal woman in her 50s. She has an ER negative, HER2 positive metastatic breast cancer, stage 4 de novo. She presented with lung mets. She developed brain mets along the course of her disease. She progressed on taxane, pertuzumab, and trastuzumab, as well as trastuzumab deruxtecan. Now, tucatinib is currently not available at our end readily. However, let's assume that she was given tucatinib and she has progressed on it, and we sent her tissue for profiling, which we don't typically do for HER2 positive, but we did it in this instance. And you can see that she has a PIK3CA mutation, as well as a Pol E mutation. So the real question here is, what can we use in terms of combination? We do have some phase 1 data that's looked at the combination of alpelisib, trastuzumab, and something targeting HER3 in patients with HER2 positive disease who have PIK3CA mutation. They got some interesting results. About 17 patients, 1 had a partial response, 14 had stable disease, and 2 had progression of disease. And we also know that patients who have a Pol E mutation tend to do better compared to those who do not have a Pol E mutation in terms of response to immunotherapy. So let's go back to this particular patient. She's HER2 positive. She's progressed on most lines of anti-HER2 that are the big guns, trastuzumab deruxtecan, pertuzumab, trastuzumab, potentially tucatinib as well. And you have a PIK3CA mutation as well as a POL-E mutation. Shani, what would you do?
So, what's the TMB?
Pardon?
The TMB.
Tumor mutation.
Mutational burden.
So her TMB is also on the higher side.
Because if you see a pole, that's likely to
It's
also be
POL-E,
high.
12.
Immunotherapy.
I would check if there's safety data to give her IO with a tyrosine kinase inhibitor. Because she does need it. She hasn't had a tyrosine kinase
No,
inhibitor.
she hasn't had tucatinib, but let's assume that she's progressed on tucatinib.
You could try, I would look to see if there's safety data for these combinations. But could consider giving her an IO with alpelisib if there's safety data. Or giving her an IO with anti-HER2 with repeat, give her Herceptin again even. But you'd need to see what safety data is available.
Okay. Senthil.
So I would do IO plus a brain-penetrating anti-HER2 therapy. So lapatinib or pyrotinib, whatever you can lay your hands on. So
Okay.
I would do IO plus that.
Okay. Nitesh, you look confused.
I want to do IV chemotherapy, actually.
You want to do what?
IV chemotherapy.
IV chemotherapy with
I want to use
anti-HER2 therapy.
gemcitabine platinum first and
Well,
get the
that's
patient.
a reasonable answer as well.
I want to do-
Moshmi, what do you think?
I just realized that the LOH is also high.
Yes, her loss of her
Okay.
genomic loss of heterozygosity
This is
is
a very
high, so
interesting
platinum-based might be something to
Yes.
think about as well. Shona, what would you do?
I'd first look for a clinical trial. Which
No clinical
obviously-
trials allowed. No clinical trials allowed.
Yeah, so I think IO-based treatment either with chemo or with alpelisib, something like that.
Okay, Dr. Abhishek?
I think I'll agree with Desh. Chemo plus platinum, she's an ER negative, right?
Yes, yes,
And we have given only taxane.
yes.
I think for a change to go back to the basics.
Okay, okay. Dr. Amol?
Based upon how much is the disease burden at present, is the oligometastatic disease on progression or what is the disease burden at present?
She's got lung mets and brain mets.
Okay,
But the brain mets is controlled.
If everything is available, I would like to go with IO plus either pyrotinib or lapatinib. So that will be my first choice considering she's TMB on higher side. I don't think so the PIK3 inhibitors and all are going to work at this particular stage, especially in third and fourth line. They hardly work in the first line itself, not that great. So how are we going to expect then post CDK4 inhibitors they're going to work? So I will go for IO plus pyrotinib or lapatinib.
Okay.
If that doesn't happen, then the last option is the cytotoxic chemo.
Okay. Anyone from the audience want to give us...
I believe we have considered radiation in this patient and done all the standard things.
The brain mets is controlled with radiation.
It's controlled with radiation.
Yes, yes. So anyone from the audience? Sudeep, would you like to tell us what you want to do for this patient? Pardon? Okay. Anyone else? All right. So, because I was hoping you would tell me what to do.
Shaheenah, what would you do?
Me, personally, I think I would try immunotherapy in this patient with a POL-E mutation. These patients really do well. We know from other tumor types. And I think that we could use chemotherapy after that, because her disease burden is not too high. If her disease burden was very high, I would be more inclined to give chemotherapy and get that rapid response. But since her disease burden is not very high, after counseling, of course, I would try immunotherapy. Pardon? PARP and IO, because of her high genomic loss of heterozygosity. I don't know if we could actually do that. I mean, PARP and IO, we have safety combination. I'm just not sure it's the correct combination. You could try immuno plus chemo with a carboplatin. I think that would also be a reasonable approach because Nitesh really wants to give chemotherapy to this patient. So that's also something to think about.
So PARP and IO is also called STING pathway. So there is evidence that if you combine IO with PARP inhibitor, they are synergistic to each other. That's called STING pathway. So that's a good idea.
Okay. So this is case number 5. Postmenopausal woman in her 50s. She's diagnosed with a right breast cancer in her 20s. She's treated. She's diagnosed with left breast cancer in her 40s. It's an ER/PR positive, HER2 negative disease. At that time in her 40s when she was diagnosed with a left breast cancer, her tissue was sent for oncotype and her recurrence score was 0. She developed bone mets in her late 40s and she was treated. She progressed on AI, fulvestrant, CDK4/6 inhibitor, and everolimus. She developed brain met, a solitary brain met that was resected, and that tissue was sent for profiling. You can see she has an ESR1 mutation, HER2 low disease, and interestingly, she's found to have an ATM deletion. So what would you do now? Aparna, do we need to test this patient for germline because she's got an ATM deletion and she's got a pretty strong not family history, but her history of bilateral breast cancer?
Exactly. So in a case like this, yes, I think germline testing is recommended. She does have an ATM deletion, so in a case where a patient can really not afford hereditary panel, at least an MLPA to confirm that this mutation is there. She has had to, she's essentially a contralateral breast cancer. So yeah, I would definitely go in for germline testing irrespective of family history. But I would take a little bit more detailed family history, not from an oncology perspective, but even from a neurological perspective, because especially in our Indian community, we do have consanguinity. In cases of ATM, there can be there can be autosomal recessive pattern of inheritance, and I think that becomes extremely important when you're counseling a patient for an ATM mutation, and it's and what it could mean for her family members if she's positive.
Shani, how frequently do you see ATM deletions in your breast cancer cohort in your part of the world?
We don't see a lot of ATM, although there are some ATM mutations from maybe our North African communities. But I've seen very few patients with ATM.
Okay. So Nitesh, tell us what you would do for this patient. This patient has progressed on all the endocrine therapeutic agents. She now has progression of disease. She has an ATM deletion. She has HER2 low disease. What are you going to give her?
I'm tempted to use an HER2 in this patient.
Okay.
It is brain. We know it's penetration in the brain, and we know that she is HER2 low. So tempted to do that.
Why not platinum-based chemotherapy? She's got an ATM deletion, so she's likely to be sensitive to that as well.
That's a good option also. But I just feel HER2 low, this is the right time to.
Okay. Can't hear you.
So there's a data if says if you have an ATM, platinums they're not the better agents there. So it's not something like BRCA or PALB2. It's ATM doesn't increase your sensitivity to platinums that much as probably a BRCA or PALB2 would do. So coming to it, I think capecitabine plus cyclophosphamide.
He wants to give capecitabine first. Senthil, what would you do?
I totally agree with what he's saying, and that the classic example is prostate cancer, right? Everybody says if it's an ATM mutated, it'll work, but so far there's no evidence.
This is not a mutation.
It's a deletion,
yeah.
But ultimately the pathway that it affects is going to be the same, right? Some may be more, some may be less, but it's unlikely to work. So I would also either do classic chemotherapy or TDXT.
Okay.
Because it's HER2 low. If you want to stick to the label, then you have to do some chemotherapy and then get on to TDXT.
Okay.
If you're not worried of those labels, then it's okay to go to TDXT straight away.
Dr. Chirag, what would you do?
I think first I would like to have a molecular tumor board. But because most of these cases there is no standard data for exact line of decision making, but either chemotherapy or trastuzumab deruxtecan.
Vineet, what would you do?
I would refer the patient.
Who would you refer the patient
because
to?
I think there are some things I know and some things I don't know, and more importantly, I know what I don't know. So these are the cases where I don't think so I want to use my computing power.
No, but practically what would you do?
That's exactly
what you would refer the patient. Okay.
That's exactly what I would do.
All right, so So Shona, Vineet has referred the patient to you and you have to give a treatment recommendation.
I'd refer it right back to him.
That is the decision of the molecular tumor board.
Shani, what would you do practically in your clinic with a patient like this?
I will comment, it's HER2 plus 1 in 5%. So I don't know, we don't really have definitions of what's HER2 low, but she's pretty close to HER2 0. So I'm a bit reticent to give her trastuzumab deruxtecan. I'd be inclined just to give her capecitabine.
Okay. Sudeep, what would you do? Okay, all right. Okay. All right, so this is the last case. This is a premenopausal woman in her 40s with ER positive, HER2 negative metastatic breast cancer. It's recurrent. In her early stage, she did receive adjuvant chemotherapy. Her tissue was sent for profiling and she was started on a CDK4/6 inhibitor plus an aromatase inhibitor. What you see on the chart over here, she has ER positivity, she's got HER2 low disease, she's got a pathogenic mutation. So question number one, and I'll direct this to you, Nitesh. She's progressed on a CDK4/6 inhibitor. Would you wait to give her trastuzumab deruxtecan, or are you inclined to give it post-CDK4/6 inhibitor? These are very practical questions that we, as oncologists, face. Do we really need to wait, say after, she's already had adjuvant chemotherapy, she's got a CDK4/6, but she also has a PIK3CA mutation. Would you give alpelisib first, or would you give trastuzumab deruxtecan first?
I think both experience and data is in favor of fulvestrant and alpelisib first. So I would do that first.
Okay.
And I guess in time, we don't know. Maybe in a few years we answer that differently. But today I'd do alpelisib and fulvestrant first.
Okay. Sorry, Senthil?
I'm sorry, I was not really concentrating on it. So is that...
So this patient has progressed on CDK4/6 and has a PIK3CA and HER2 that's low. Would you give trastuzumab
I told you already
deruxtecan
that
or alpelisib?
I'm not a great fan of alpelisib. So if I get TDXT, I will do TDXT rather than doing alpelisib.
All right, Vineet, what would you do?
Exactly 2 and 1.
2 and 1, what does that mean?
So
In
the
that
second
sequence.
option would be my actual first choice, and then if she progresses, then I go to 1.
Okay, all right, that's what you... Shona, what would you do? Shona?
Shona ji, just one question.
Okay.
Does the time taken to progress on the CDK4/6 influence your choices? Say she progresses within 6 months, beyond 6 months, does that make a difference?
So let's redirect that question. It's a very good question. Let's redirect that question back to Nitesh. Say suppose the PFS on CDK4/6 was 3 months versus 12 months. Would that change your scenario?
And this biopsy was done at progression or before because this is done before progression. If she's got an ESR1 mutation also gained.
Before progression.
Yeah, so you see, I still feel comfortable using fulvestrant and finishing that first, but I buy the point of that what Devrat is trying to say, this patient is in fact behaving more aggressively and with in fact HER2 0 data also being tested on. But I would still use fulvestrant first.
Okay. Vineet?
So I think it's it's important to test her BRCA status.
We're coming to her BRCA status, Shona. We're coming to it.
Because these guys don't respond to CDK4/6 that well. And if she is positive, then put her on a PARP inhibitor. Otherwise, probably do fulvestrant with alpelisib.
Okay. Shani, what would you do?
If she's got...
We have 59 seconds left.
If she has endocrine resistance, so if she's progressed very rapidly on the CDK4/6 inhibitor and the aromatase inhibitor, I would go and give her the Enhertu. But if she'd had a prolonged response, I think she can have a trial of the alpelisib.
Okay, so last question to you, Shani. If this patient had a BRCA mutation and had a very short PFS with CDK4/6, which is what we typically tend to see in patients with BRCA mutation, would you go for PARP or Enhertu?
PARP.
Well, thank you very much, and I've given you 24 seconds spare before we go to the next session. So thank you all. You've been wonderful. Thank you so much.